All right. So maybe, come on, thing work. All right. First thing I want to show you guys is this video about polytrauma rehab in the VA. Okay.
They understand the veteran's perspective, being in a military environment.
The therapy he's received here has really brought him to where he is today.
I believe there was no better place in the world for Ryan to be.
Our team members don't just think about their own discipline. They really look at that veteran or that service member as a whole.
They honestly love what they're doing and they want to help, just to have the compassion.
So, Allison, tell me a couple things that you picked up there in that video. Did you pick up on some specific issues, or what stuck out with these patients?
I'm not really sure.
Okay, somebody want to help her out? Isaiah, what stuck out to you about those patients you just saw? What was different about them compared to other patients?
Honestly, it went by a little too fast.
Okay. Did anybody pick up on some stuff?
Well, they're veterans.
Okay, right. Which is a very common group with polytrauma. Why? Why do you think patients in the VA are common patients that you're dealing with polytrauma?
You'll often have somebody who has an injury, but also has post-traumatic stress or other cognitive issues.
Right, right. So that was kind of the purpose of that video, was showing you that, there are different types of polytrauma. There's, the physical side of it, but there also can be, mental diagnoses and things that come along with traumas that also affect the patient. That they could be doing with comorbid polytrauma, and just comorbid diagnoses in general are every patient. It'll be very rare that you ever see a patient that just has one diagnosis. You might have one diagnosis that you're primarily treating, but there's probably also something else underlying, whether it be a mental diagnosis from trauma or something, or from physical injuries or fractures or whatever it be. It's very rare you're going to treat somebody with just one thing. So what kind of injuries do you think are common with polytrauma? Cassidy, what kind of fractures do you think are common with polytrauma?
I don't know. Like bone fractures and stuff like that. Is that what you mean?
Right. What do you think are some of the more common fractures that we see?
Oh, I don't know. Like, I don't know what you mean.
What are some common fractures that occupational therapy
Like
treats?
if you're like in a car accident, maybe you broke bones in your hand and your arm.
Okay.
And then maybe you also have something that happened on the same side leg.
Okay, what do you think is more common? Do you think we're more commonly treating people with rib fractures or people with broken arms or broken hips? Or
I would say it's like extremities, like limbs and stuff.
Right. Extremity fractures are definitely the more common ones. And, I'm glad you brought up the example of car wrecks, which is kind of what a lot of this chapter is about, or you can relate it to, because you're talking about a very traumatic event that can relate to multiple things. So very good. What kind of brain injuries are we talking about with polytrauma? What are some more common types of brain injuries?
Maybe a TBI.
Okay. What else?
Concussion, maybe?
Yeah. Remember, concussions is like a very, very mild TBI, but yeah. What about like brain bleeds? Stuff like that. We're going to stay with that example of car wrecks throughout this chapter, so kind of keep that in mind. So you may see a patient and the acute care. You may see them in a long-term facility or a rehab, inpatient rehab facility, and you're treating them for several things. They may have had a TBI, and they may have had, a broken leg or broken arm, broken wrist, whatever on top of that. That's what polytrauma is. As far as what kind of thoracic and abdominal injuries or internal injuries, that really can vary person to person. It really depends on the trauma. What is a superficial injury? Maggie, what does that mean?
Like on the outside, so like a gash or a cut or a burn or
Right.
something like that.
It's literally, what Maggie's talking about. It's like an injury to the skin. It's outward. Okay. And then spinal cord and nervous system injuries, that's extremely common, right? We've talked about the idea of polytrauma with spinal cord injuries, how a lot of them also have a TBI of some sort because they've related in some type of a trauma. So, all right. So what other conditions or causes are associated with polytrauma? What does anybody want to describe what shock or sepsis is? What does that mean, Isaiah? What is shock?
I don't know the textbook definition, but in my head, I think of someone who's like almost in the freeze of fight or flight post like a traumatic experience.
That's exactly right. That's exactly what shock is. Your body is literally trying to survive. It is in a fight or flight response. So what differs between shock and sepsis, Cassidy?
I thought like sepsis was like an infection that took over your body.
It is, exactly. So what they can actually look similar, right? Shock is kind of, how can I put this? The body is literally like, I hate to use the word to define it, but in shock. Their body has experienced a trauma. Their body doesn't know exactly how to respond, so it just goes into shock, almost in just a I need to survive mode. With sepsis, this is like an internal infection that has gotten into the bloodstream, and the whole body is dealing with infection. So it's not just like one area that the body's trying to get to heal or to get rid of the infection. The whole body is dealing with it. So this leads us into that next question of critical illnesses. When a patient is septic, it is critical. If they do not get help, they'll die. 99% of the time, if the patient is septic, they're in the ICU, getting some super, super strong antibiotics and under constant monitoring because that person can die quickly. One common cause of sepsis that a lot of people don't know is UTIs, untreated UTIs. They can't feel it. We talked about the idea of diabetics getting a lot of UTIs. And they'll get to the point where they don't know that they have one, and it stays there and stays there and stays there. And then all of a sudden, it's gotten so bad that they become septic, and it's like, boom, it's a scary thing. So it's important to, talk about that. But for as far as polytrauma goes with sepsis, a lot of patients can get that type of infection or that really bad critical illness from injuries and the bacteria and whatnot getting into the wounds. And the body just can't heal. So it goes septic, and it needs additional help from really, really strong antibiotics to fight off whatever is going on. So I brought up the term comorbidities a little bit ago. What is an example of a comorbidity, Lindsay? Any comorbidity that we've talked about?
Just when you have multiple diagnoses?
Right. So give me an example.
I don't know, like a CVA and high blood pressure? I don't.
Absolutely. That's an extremely common comorbidity. Right. So literally what it means is two diagnoses, right? They're acting on each other. That was a perfect example, Lindsay said, was high blood pressure and strokes. Those are directly related comorbidities. But there also are certain things that can impact treatment that we need to be aware of. A big one is kidney issues. If a patient is having a lot of kidney issues, their body doesn't filter, doesn't do medication well, especially pain medications, that can be very difficult to treat certain things. Kidney issues and liver issues really limit, what a doctor can prescribe somebody. They can't just, do like a lot of people can, just go take some Advil for some back pain. It really takes a lot of planning, the right medication under doctor supervision to even take something over the counter. So comorbidities can really throw a wrench in treatment. I've talked to you guys several times about my grandma, who is actually the reason I'm in Florida. I flew her down here, and she has every comorbidity I swear you could ever ask for. Problems that she could write a book on. But, she has really bad kidney issues, and she is unable to take a lot of medications, and her back hurts her all of the time. And I have watched how that affects treatment. I don't treat family. I'm not supposed to treat family. But I've watched other therapists and stuff come in and work with her. And there are a lot of limitations of what she can do because she is in pain, but she really can't take anything for it. That is the case a lot of times with this polytrauma stuff. There's certain factors that are going on that will inhibit what you can and cannot do with a patient. One little kind of a pop quiz question that you're going to see a lot with polytrauma, especially in early stages, is a DVT. Allison, what is a DVT?
Is it the deep vein thrombosis?
Right. So what is really important to know about that, Faith? If you see the diagnosis of a DVT on a patient's chart, or they say this patient has a DVT, what is really, really important to know?
Oh, sorry, I was muted.
Okay, so I can't see you on screen. I can just see the PowerPoint. So
I was just saying that if they have a DVT, they shouldn't be like up on their legs walking around doing strenuous sessions and therapy.
Can you treat a patient with a DVT?
Yes. Yes.
Okay. What does that look like, Cassidy?
Having them seated.
Having them
Working
seated.
on maybe I guess if it's like an upper extremity one, but I don't know. Having them seated.
Okay. Seated where?
In their bed or like edge of bed or like on a chair or something.
Very good. Cool. Awesome. So we've kind of talked a lot about these different body systems, but I want to run through them briefly to talk about, what comorbidities you can see with these. Neurological system. One really, really common thing is neuropathy, right? You may have a patient who you really need to work on some strengthening with or some balance with or whatever it be, and they have neuropathy in their feet or their hands. That's really difficult to get under control. First off, because their medications that they treat that with are, restricted medications. They're under lock and key. They're not really all out there because people abuse them. So say you have this patient who you need to do these exercises with, okay? They have neuropathy or they have nerve damage from a traumatic event. How do you get them to work with you, Isaiah? What can you do if, let's stick with the car wreck thing. They have a broken arm from their car wreck, but they also have nerve damage that causes extreme pain in their hands. How can you get them to do some strengthening exercises with you? Or what are some tips that make that easier?
So they have an injury to their hand, but they also have lack of sensation, right?
No, they have like a fracture in one of their upper extremities, but they also have nerve damage that's causing extreme pain in their hands.
Okay.
They're hypersensitive, not hyposensitive.
Okay.
Okay. So how can you get them to work with you on some type of a strengthening activity? Because that's what they're needing.
Yeah. My brain just goes to passive range of motion at first, because that would make it where it'd be slower and more in controlled by me. But I'm not sure that's what you're looking for.
Not exactly. Remember, range of motion itself is not a strengthening activity at all. It's just for range of motion. Lindsay, you want to help him out? How do you get a patient that has a lot of pain in their hands from a nerve damage to work on you with some strengthening stuff?
I guess I would base it around like their medication schedule.
Right. Absolutely. That's exactly right. So you want to base it around, if somebody has nerve damage, they're probably getting some type of a nerve pain pill at some point throughout the day. And those wear off. Talk to anybody who takes those, they don't last all day. And it takes a little while for them to kick in. So basing treatment around that is going to be a huge help. Another tip would be starting out light with stuff, working on, because nerve damage you can work with and help, in theory, eventually through massage and whatnot. But, starting out light with something that's not going to cause a ton of pain in their hands, or not going to increase the pain in their hands. We've already kind of talked about the skeletal system and your muscles and whatnot. What are some comorbidities with that? If somebody has muscle tears, they have osteoporosis, all of these different things. Those all count as comorbidities. Cardiopulmonary system, CHF or COPD. If somebody is dealing with these issues about with their breathing and not getting enough blood supply, that's going to really make treatment a lot more difficult. It would be hard for any of us if we were trying to, do an exercise or do an activity and we're constantly out of breath. We have a ton of swelling in our legs, and, it makes it difficult for us to, move around. That's what these patients are living in. So trying to. Now, what does OTA with any of this? Why are we even talking about this? Every one of these comorbidities affects treatment, all of them. You can't have a patient who's come in with a hip replacement and say, okay, we're going to do some upper body strengthening for, transfers, increasing transfers, if they have COPD. Because now they're fighting, pain in their hip. And on top of that, they're having issues breathing, two totally separate issues. You're primarily seeing them for rehab for a broken hip, but they have COPD on top of that. So that's the idea that I'm wanting to get through to you guys is when you see a patient's chart, 99% of the time they're going to have more than one diagnosis, and you are treating one primary diagnosis, but you need to be aware of all the other ones that are involved. A big comorbidity is dementia at whatever level it may be. That might not be the primary reason that you're treating them. The reason I keep bringing up hip fractures is that is a common one. They're in rehab for a falling and breaking their hip, but they also have dementia or COPD or something else underlying that really impacts your treatment. So how can a client's premorbid condition affect the recovery from polytrauma? Faith, how premorbid condition means like before they got injured, whatever reason that you're seeing them for treatment, okay, what they had before that, how does that affect treatment?
I guess it would just affect the way that you have to do treatment if you had with precautions and everything. Right.
A lot of precautions, for sure. Are you going to give a patient who, has a pretty severe case of dementia, are you going to give them a visual handout for a home exercise program or for their visual or their precautions, like their weight bearing precautions? How are you going to teach them that?
Yeah, I would say not to give them a visual just because they're not gonna, they might just place that paper down somewhere and never look at it again.
Okay.
Maybe just you would have to teach the family member or the caretaker so that they could work on it with them while you're not there.
You guys are doing really good with these answers for sure. This is the kind of stuff that you guys have to be aware of, especially coming up into these next couple of practicals. Um, Remembering that if there is a certain diagnosis, all these different, common treatment interventions that we have talked to you guys about, sometimes those literally just fly out the window because there's a comorbid diagnosis that makes those kind of null and void. I like the way that you said it, Faith, that you might give a visual handout to somebody that has dementia and they just sit it down. I mean, they're never going to look at that. But the backup to that is teaching a nurse, a CNA, their caregiver, whoever, hey, this is their, they are abiding by these. It might be recommending, hey, I really don't think this person should be at home by themselves. They really need 24-hour supervision. It could be something like that. So that was really good. Teaching the caregiver is a really good thing, a really good way to go around some different comorbid diagnoses. Good job. Are there any questions so far? All right.
I have a question.
Okay.
Do you ever run into like any problems with teaching like a nurse or CNA things? Like, do they ever think like, oh yeah, you don't need to teach me this?
Yeah, it's actually quite difficult to teach. The most difficult person to teach is another healthcare profession, unfortunately. That's very difficult, and it shouldn't be that way. It's almost like they see it as stepping on your toes, and I feel like we would all be the same way too. Think about it. If you're out there and you've been practicing for a couple of years and then a PT comes up and shows you, oh no, you should do it this way, it's going to step on your toes too. Especially if you're trying to teach a CNA that's done this for 30 years on transferring a patient. I'm like, here's a better way to do it. What are you talking about? Sometimes it can be very difficult. On top of that, it's also an issue with them being overworked and being short staffed. So you may say, hey, you're doing too much for that patient. You need to let them, do as much as possible when you're getting them up in the mornings, especially in long-term cares. And they'll be like, I have an hour to get these patients up and ready, dressed and ready to go for breakfast. I don't have time to let them just do whatever they want to do. So it really is a catch-22, but absolutely. I can't see her, but is Professor Turley still on?
I don't think so.
Okay, I was going to ask her if she wanted to chime in, but I know she has also dealt with this. Long-term care, it's difficult because they are overworked, they are understaffed, and then trying to teach them something new on their job it is difficult and often ill-received. But it's part of the job. You're an advocate for the patient, regardless. Are there any other questions? All right. So let's talk about some surgical stuff. What is the focus of the different phases of trauma care? You have pre-hospital, acute care, and rehabilitative care. What is pre-hospital treatment or trauma care, Maggie?
I'm guessing like if you had someone that maybe had I'm just guessing with this, but like a diabetes diagnosis, and they were at home, things were going okay, you're taking care of them, something starts to go wrong, and you're taking care of them before things get bad enough that they need to go to the hospital. Maybe.
You kind of went a different way. Let me rephrase it for you. So there's a traumatic event, okay, and someone calls 911, okay? What does that help you?
Oh, yeah, okay. So that's like, I feel like that's a really critical time, but
who would be in pre-hospital care? So a traumatic event happens, boom, care starts right then. Who is involved in pre-hospital care?
Whoever's around.
And then who?
Like EMTs.
Right. Your ambulance drivers. That's what I'm
Okay.
gonna. The pre-hospital care. That's very critical. Often, and I'm not downplaying ambulance drivers by any stretch, but I've ran into some in my career that are extremely questionable in what they do. I appreciate everything they do, and I'm not downplaying it at all. But I've also, had some bad experiences. You have a patient who fell and fractured their hip. They're not supposed to get up with a fractured hip, and you have to stabilize that joint to prevent any further damage. All of that good stuff. And I've seen them like pick patients up and have them walk to the, or attempt to walk anyway, to the, gurney to get in an ambulance. Those kind of things can happen. Trauma care is extremely critical, even before hospitalization. Right from the get-go, the correct protocol has to be followed from all the way forward. Think about a heart attack. We talked about nitroglycerin pills. If somebody is having chest pains or whatever and they have nitros, to give them a nitro and see if it goes away. If not, call an ambulance, right? Like that's the kind of pre-hospital care I'm talking about. So then we bring them into the hospital. The biggest focus is, what are they able to do? Focus on what are they able to do, and then working on what they're not able to. Basic ADL stuff. And then back to rehabilitative care, that's what we've talked about pretty much all semester, just working on tasks and things, trying to get them to the point where they can, go home, live normal life as much as possible. So what kind of surgical intervention may be necessary in the acute care phase? We've talked a little bit about these, and I'm just going to kind of touch on them. I have a couple good videos I want to get to today, and I don't want to keep you guys the entire time anyhow. But cardiovascular, they could be doing heart caths, stent placements, open heart surgeries. Intracranial, that's your brain surgery, for all kinds of different reasons. Could be fixing an aneurysm, could be removing a tumor, could be a lot of different things. The more common ones that we're going to see in orthopedics, hip fractures, shoulder replacements, knee replacements, any kind of fracture repair, that's super, super common. Neurosurgical, that could be like a nerve repair, which have good results, don't. All I'm going to tell you with neurosurgical is it takes a good surgeon. I've seen some patients who have nerve repairs and they do really, really well with it. And I've seen some that they lose feeling altogether. I've definitely seen a wide variety of things with neuro, like nerve repair surgeries. So, and then abdominal, having pancreas removed, or not pancreas, goodness, gallbladder removed, stuff like that. Another really common one is having a colostomy bag. Have you guys ever ran into or know somebody who has a colostomy bag? And I can't see you guys, so you have to speak up and tell me.
I had to clean a couple before.
You have?
Yeah.
What was that experience like?
It's a little yucky.
Mhm.
Obviously it smells, but I feel like you also have to just like be compassionate about it because they are going through the same thing and they have this sack of stuff on them, so they obviously are probably embarrassed by it, and I just feel like you have to be nice about it even though it's super disgusting.
It's you hit the nail right on the head. The patient hates it just as much as you are. One cool thing that you guys should be aware of, because I've recommended these to several patients and they love them. I can't remember the brand, but there's these drops that you can get that they can put into the bag, like when they're changing it out. And then whatever goes in, it completely renders it odorless. There is absolutely nothing. I know this sounds gross, but I'm going to say it anyway. You could literally stick your nose into the bag and sniff. Won't smell anything. It's really, really good. It's a great tool to have for patients. And it's a good thing to recommend because a lot of them are embarrassed by it, or they like to keep it hidden. But it's part of the job. One thing I will tell you guys as far as OTA is, we're not there to clean, replace the bag, whatnot. That's a nursing job. That's not ours. What we are concerned on is teaching them how to manage it, how to take it on and off, how to get themselves clean, how to replace a new one. That is something that takes some service competency in for sure, either from an OT, or you can get training from a nurse to do that. So check out the different avenues of getting certified and something like that. It's not you don't get a special certification, but you do need to prove service competency before you're teaching someone else how to do it. So anyway, are there any questions so far, or are we good? Okay. All right, so let's talk about some medications. So what type of medications are typically needed after polytrauma, and why are they necessary? So sedation, why is that needed in polytrauma, Isaiah?
You have a lot of pain and a lot of things going on, and you want to slow down the biological processes to keep them alive longer. It's the same thing that shock does for our body, but we're just doing it manually.
Okay. So why do you... Okay. Another big reason for sedation is patients get freaked out and react a lot to polytrauma situations, fresh traumatic events, and they'll be in the hospital and they may be unconscious or whatever, and they have all these lines and stuff in them, right? And they go to wake up and they're ripping things out, crazy stuff. So they'll keep a patient sedated to keep them from doing stuff like that. And then you have pain medications. Those are clearly needed, right? Strong pain medications. If you have something going on where you had a TBI and a broken hip, broken arm, whatever, clearly you're going to need pain medication. Cardiopulmonary medications. Sometimes when they go through traumatic events, their blood pressure will spike and stay there at a very dangerous level, and put them at risk of stroke and heart attack. So they may give them medications to bring that blood pressure back down. It really just depends on the patient. And then cognitive stimulants. Let me think. Who hasn't talked in a minute? Maggie, what is a cognitive stimulant? Not like a brand name or a specific medication, but what are they?
I'm trying to think. I'm kind of like not thinking well this morning, but
Go get you some coffee.
I didn't, and I should have. I guess just
don't overthink it. It's definitely a play off words.
Keeping them alert, aware. I'm not sure all the way, but that's
you're getting it. You're getting like these patients that may have, after polytrauma, they're sleeping a lot or feel like they're zoned out, something like that. They may need some type of a stimulant to get treatment going, right? To keep them awake and alert and able to make decisions and stuff like that. Those are a little less common than the other two for sure. Definitely stuff to keep blood pressure and blood under control, sedation, and pain medications. Those are the three biggies. So how might these medications be administered and monitored? If we're talking about the hospital, like 98% of the time, it's going to be with some type of an IV line. Pain medication a lot of times goes through IV lines. Excuse me. And then, oral pills. I wanted to show you guys, this is a mobility education video about the intensive care unit. I want you guys to take note of how they're moving the patient, but keeping all of these different types of lines and tubes and stuff in, okay?
System has a mobility program for patients admitted to intensive care. The program is called Progressive Mobility. Progressive Mobility is a step-by-step progression of activity from turning side to sitting upright, sitting on the bedside, standing and getting into the chair, and walking both in and outside of their room. Research studies have shown that progressive mobility programs are safe and effective with patients in intensive care requiring a breathing machine or ventilator. Activities will be supervised by the ICU team who have been specifically trained in progressive mobility. The goal of progressive mobility is to maintain the highest level of physical activity that the patient is able to perform during their illness. This helps to prevent complications of immobility, such as muscle weakness, pneumonia, and skin breakdown. Progressive mobility will begin as soon as the patient is awake and able to engage in activity, perhaps even on the first or second day of hospitalization. Until then, the staff will turn your loved one from side to side and move their arms and legs to keep them limber. If you would like to participate, you can be shown how to do passive range of motion, which is moving arms and legs at the joints to prevent stiffness and promote circulation. There are handouts and a video on YouTube to aid in your learning. During progressive mobility sessions, you can be an active partner by explaining the process and encouraging their full participation, as well.
We'll stop right here for a second. You literally are looking at 5 healthcare professionals involved in keeping this man and all of his lines like stabilized. How crazy would it be? Remember how we've talked about transfers before? And I said, really, if you get more than 2, it's difficult because you need a clear leader. It shouldn't be 2 people pulling in different directions. You need a clear vision before you do a transfer. Everything, all the directions need to be clear. Now try doing that with 5 people and all of these lines involved. Faith and Jennifer, I'm sure you both will see a lot of things like this when you are working at or when you're in your rotations at CAMC. Working with patients in this type of care is extremely difficult. These lines cannot be pulled. They cannot be, moved. So trying to keep all of that stable throughout a transfer is very, very difficult.
As well as reassuring them of their safety. Each new step reached will be noted on the whiteboard in the room, and the progress made shared with the ICU team. The progressive mobility steps are: Step 1, bed rest, turn side to side. Step 2, supine exercise in bed. Step 3, bed mobility, able to move self around in the bed.
All right, sir, we're going to go ahead and bring your arm up, find the ledge up here. Pull that. Oh, you wanted me to leave the head up a little bit? Yes. Okay. Can you bend your knees for us? Good. And on the count of 3, we're going to go up into the bed. 1, 2.
Step 4, dangle legs at the bedside.
Okay, once you're in sitting position, I'm going to help you assist with your leg to the side, and you're going to take the back to the side and dangle your feet.
My name is Jeff. I'm from Respiratory. I'm just going to be stabilizing your breathing tube here. Okay.
All right, buddy.
So take note, we have a specialist here from respiratory therapy. Okay. Probably, I didn't catch, I think this guy was the nurse and this guy was the therapist, or this lady was the therapist. I can't remember which one, but already you have 3 players and all you're doing is sitting him on the set, dangling his legs on the side of the bed.
Amy's going to assist you back.
Great.
Good. Okay.
Step 4, get out of bed to the chair.
All right, we're going to get you up. Good. Stand up nice and tall. Excellent. They're not going to fall. Come on, steps. Careful. Put your hand on the chair. Put your hand on the chair. Right? What? Okay.
Step 6.
So that other lady was a family member. I think, Lindsay, why would a family member be beneficial to have in that situation?
I don't know. To, I guess, like, provide a little more motivation and try to make the patient a little more comfortable because they know them.
Absolutely.
They're scared because they can't even say anything.
What would you say about his alertness?
I mean, he's pretty alert.
You think so?
Well, I mean, his eyes are open and he's walking. I felt like that was pretty good.
Well, let me ask you, whenever he stood up, did he look directly at, we'll just say it was his wife. Did he look directly at his wife, or where was he looking? Did anybody notice it? Let me just replay it. Watch his eyes.
Good. Stand up nice and tall. Excellent. They're not going to fall. Come on, steps. Careful. Put your hand on the chair. Put your hand on the chair. Right? What? Okay.
Okay, so where did you see his eyes go, Lindsay?
They were kind of googly, honestly. I guess like they looked at the ceiling first, and then it seemed like he like then had to get oriented, and then he looked at his wife.
Right, right. So that's what they're actually using her for in this situation is orientation. Finding something familiar like his wife's face or whoever she is face that he can focus on while they're moving him, right? Something that makes the situation a little bit familiar. That's a cool tactic to use. They're not so freaked out. They're not surrounded by all these people that are touching them, moving them, holding these tubes coming out literally out of their mouth. And then they see somebody familiar. It helps to get them focused on the situation and less focused on what's going on. If that kind of makes sense. We want them to be aware, of course, of transferring and where to put your hands and whatnot, but putting a familiar face in the situation is going to help them feel more comfortable with what's going on.
Step 6. Walks in the room.
Okay. So ready? We're going to stand up and walk a little bit. Okay? So hands here. Lean forward. Push up. And then reach for the walker. Good. Stand up nice and tall. There you go. You feel dizzy? Nice and slow. Good. Stand up tall.
Step 7. Walks out of the room to the hallway.
Video.
Thank you for your participation in your loved one's care. We will be happy to answer questions about the mobility process at any time.
All right, so real quick, I want to see if I can see you guys. So Faith, tell me what you saw in that video. What, because that's going to be a common situation that you're going to see on your fieldwork rotation. What stuck out to you about that?
I think something that really stuck out was, like you said, working with a lot of different healthcare providers at once, just to do something simple as sitting him on the side of the bed. So it makes you think that you're not going to be doing extensive therapy and all these different unique therapy techniques. It's really just simple stuff.
Right. Which is kind of what you're seeing in, in acute care. You're not seeing this super extensive ADL program. You're kind of working with, somebody who it might take 3 healthcare professionals just to sit them on the side of the bed. And he was, an average sized man, right? He didn't feel like if he didn't have all these different tubes and issues and stuff going on, you could sit him on the side of the bed pretty independently, right? But in the situation and the level of care he was in, you needed 3 people just to manage a safe transfer to sit on the side of the bed. So it's a little bit of a different world when you're talking about, ICU, acute care, and all this polytrauma stuff, right? All right, let's go back to the PowerPoint real quick. Okay, so we've kind of covered a lot of this slide already. I'll touch on it a little bit, but how can polytrauma affect the following body structures and function: range of motion and muscle strength? We've talked about the importance of keeping range of motion in all of their joints, especially if they're sedated and not able to move them. And muscle strength, every day you lay in bed, a rule of thumb is it takes about 3 days to gain that muscle strength back, that muscle tone back. Motor control and praxis, it really just depends on the trauma and the level of trauma for pretty much all of these: balance and posture, sensation and pain, arousal and cognition. A lot of these are going to be affected different. If you're talking about somebody who has a TBI compared to multiple bone fractures, they're going to react, and these systems and structures are going to be completely affected in a different way. One area I really wanted to touch on with this slide, though, was COVID treatment. With you guys emerging as practitioners right now, kind of coming out or whatever we are in right now with the pandemic, you guys are going to see a lot of post-COVID patients, and I want you guys to see what occupational therapy is doing with COVID-19 patients.
I am Lauren Hawkins. I am an occupational therapist. Floor. When the patients first came to the inpatient rehab floor, they were extremely debilitated, had very little endurance and muscular strength. And so we started with the basics, just working on sitting up on the edge of the bed, because when you're on a ventilator, you're pretty much laying down or you're prone on your stomach. Then we were able to get into standing, and then we were able to work on maybe standing at the sink and shaving. And then we're able to progress to walking to the bathroom. So just taking those little steps, hitting little goals along the way. So kind of just going back to the basics and then going from there was the best way. Anytime we do therapy with somebody, we always want to include their interests or what makes them happy, or what do they want to do, have to do, need to do. So that somebody who's 74 and retired, their interests and hobbies are going to be a lot different than the young girl who's in her 20s and 30s who may have a child to take care of or may still be trying to get back to work. So just incorporating those different things, but still overall going towards the same outcome for independence. Our average length of stay for general patients is about 2 weeks, and so we're finding out just a little bit extra time is what they're needing to go home. When they're coming from the ICU, we're finding that their self-care, so their ability to take care of themselves, has been lowered. Their level of independence and even walking and standing is gone completely down, just from the prolonged time on the ventilator and just being in the hospital in general. Our goal with inpatient rehab, just speaking from my point of view, is to get patients as independent and safe as possible. So it's not expected that they'll be back to normal when they go home. A lot of patients are going home with home health care to continue working in their home environment. So it's not expected when they leave the hospital that their journey is done and their therapy is done. It's going to continue for a while before they get back to what they consider their normal. meet all of his goals that he wanted to do. It's just not a lot of tears from us, just more joy.
So, what are some things that you would expect to see post-COVID, Maggie, from patients?
Weakness, poor activity tolerance, just overall general weakness and poor
So
respiratory.
one that you said I really want to touch on, the weakness comes with just about any hospitalization, but the activity tolerance is huge with COVID patients. I've treated several now, and I've treated all of them in home health. So they're, kind of toward the later stages of therapy, and the perfect continuum. The only other thing would be outpatient, and their level of activity tolerance is extremely low. They get wore out very, very easy. It's almost like treating somebody with a severe case of COPD. Their level of activity tolerance is so low, like you could say eating breakfast would wear them out. Making a bowl of cereal will wear them out, and they'll need naps and long rest breaks. So one of the biggest things you're going to be working on is literally activity tolerance, that gold standard goal that we've kind of talked about, saying that, this patient needs to work on just being up, sitting on the edge of the bed, even if it's just playing a card game. Something very low can be very beneficial, especially in the earlier stages of COVID recovery in the acute setting. So let's move on here to our intervention and common goals. Does anybody have any questions or comments, concerns? Are we good? Okay. So what is our role in treatment? I think by this point you guys are pretty good on what we do as OTAs, but with polytrauma, our role in treatment is understanding what is causing the issues. You may have a goal for the patient to increase their independence in upper body dressing, okay? But if you go in and you see that it's not that they don't know how to put on a shirt, but it is that, the range of motion sucks. The fine motor coordination sucks. They can't grip the shirt. They can't manipulate the shirt to get their arm through the hole. Finding out what is that underlying issue, okay? Is it something from a polytrauma event? Is it a comorbid diagnosis? What are we treating? That's what you want to attack. Yeah, a lot of times you're going to have a limited amount of time anyway with these patients, and you don't want to waste time. You want to do what's going to be the most beneficial for the patient. Do you want to have them take their shirt, on and off 15, 20 times? Sure, you could. Or you could do like a really good range of motion activity to try to get their arms up or their hands working or whatever the underlying issue is. That's where I want you to start transferring your thinking with interventions. You need to get to the underlying cause of why this goal would even exist. Are you seeing this patient? They have a broken hip. That's what's causing it. Okay. Well, we need to treat, the broken hip. I'm not saying that you can't teach them comp strategies or adaptive equipment or whatever, but if it's something that's, supposed to, or in theory, they're going to, you need to help them focus on why can't you put your shirt, your pants, your socks, shoes, whatever, on right now. Like, what is that underlying, and treat that. You're going to get much better results that way. So what is the general focus and goals on treatment in different phases? Acute care, it really just depends where they're at in that acute care. Are they in ICU? ADLs are going to be a big point, but even as low as just doing passive range of motion with somebody is going to go a long way. Inpatient rehab, like Odysseys and places like that, those are just about, how can I put this? They almost look like an outpatient clinic in a hospital type, I guess. That's not a really great way to describe it, but it kind of looks like an outpatient clinic that's either in a hospital or dedicated just for a rehab facility. And these are intense. A lot of times these are long hours of treatment. Some of these places like Encompass, you may go and have literally like 5 and 6 hours of treatment a day, but they do get pretty amazing results. Oop, who's in the lobby? Oh, Professor Trent. So, those kind of places, I always recommend when somebody has any kind of polytrauma event, stroke, anything, they need intense therapy. One bad part is when they skip a lot of these steps. Patient says, oh, I want to go home. Doctor says, okay, I'll send you home with therapy. That's not the way it should go. You have acute care, and then they're like, boom, we're sending them to home health. Well, home health is like 2 to 3 times maybe a week for about 30 to 45 minutes. And they should not skip all these steps, but unfortunately they do sometimes. And, I've often said, hey, I've called the OT. I said, can we get them a referral to go back to Encompass or just somewhere where they can, get the rehab that they need, because you just physically can't do it. Your schedule does not allow for that. So, don't be afraid to speak up and mention those kind of things. If you feel like that they're not in the right placement for some reason, like a choice, they were at the hospital and they said, oh, I want to go home, I'm not going there. You may need to educate them. I've done many, many times. And then continuing down into skilled nursing facility, that's a lot of ADLs. At this point, you could be working on comp strategies, adaptive equipment, strengthening range of motion, whatever it be, to get them independent in ADLs. Home health is, where my heart is. I feel like it's very true, OT, because you're working with what they have in their environment. And you're going to be working with their specific stuff to do their ADLs. And, you can't really mimic that. And then lastly, outpatient, if it's needed, you're working on mainly an outpatient range of motion, strengthening, pain management, stuff like that. So how is treatment and recovery affected by prolonged immobility? If somebody is immobile for a longer period of time, their treatment and recovery is going to take a longer time. Again, that whole idea of 1 to 3 days on, losing strength, how long it takes to gain anything like that back. And then behavioral and emotional factors. Unfortunately, you're probably going to, at some point in your career, treat a very sad situation. Let's say a car wreck. And I've treated this actually several times, unfortunately. But, one person in the car survived, and that's who you're treating. There's a lot of things like that you're going to have to deal with too. You may end up having to talk to a patient about something like that. And the emotional side of that, maybe getting, a different healthcare professional involved, psychiatry, whatever, a counselor, somebody for them to talk to. Don't be afraid. Don't shy away from those things. These are real issues the patient is facing. They are very difficult to talk about, but it's part of your job to make them aware that there are services out there for them to talk to try to find whatever they need. Okay. Any question? All right. Almost done, guys. So monitoring client safety. Why might it be necessary to have 2 treaters? Again, you guys saw it in that video. It might be necessary to have 5 people involved in a transfer if it's that many tubes and things that need to be monitored. It really just depends on the situation. What equipment and supplies should you have? Let's give an example, make these questions a little easier. Let's say that they were in a car accident and they have a fractured right tibia. Okay. Cassidy, what equipment and supplies might you have when you go in and see them? Let's put them in acute care.
So acute ADLs, so maybe like a shoehorn or like a dressing stick or something.
Okay.
Or like a long-handled spun. No. Maybe, I don't know. I guess it just really depends on where they're at if you're going to start doing shower stuff, but definitely stuff for dressing.
Okay. What precautions might be in place, Maggie?
What was the I know they're in the car wreck, but it kind of cut out on me. I couldn't hear exactly what you said.
Sorry, a fractured right tibia in acute care.
Just making sure that you're watching that wrist or that bone, and I'm sure it's in a sling or like they're protecting it some ways and making sure that they understand they have to watch it and just be careful with it.
Okay, so you're going to be focusing a lot of precautions if it's a fractured right tibia on lower body weight bearing precautions, right?
Oh God, I'm sorry.
Maggie, you need some coffee.
I really do.
So weight bearing is going to be huge. These patients, they're probably going to be in some form of a cast, maybe an immobilizer or whatever. It depends on the extent of the fracture, but definitely making sure that you're right on your precautions for sure. Watching it, making sure that they're aware of what they're supposed to be doing. So what is the procedure before starting a treatment session with this patient? What do you think, Faith? What would you walk me through starting a treatment session?
Well, you would introduce yourself and explain to them why you're there. Ask about their pain levels because you don't want to overexert what they can't do.
Mm-hmm.
And maybe ask what their goals are.
Yeah.
Getting back into their ADLs, but also doing what their doctors are allowing them to do.
Right. So kind of what I would call that we've not really branched into, like giving that a term, because you kind of walk through the beginning of a practical, right? Like taking their blood pressure, asking their pain levels, getting to know what their goals are. That's like the beginning stages. What you're really doing is, you're orienting yourself to the patient and making them feel comfortable with you because you're learning all about them. So that's what you're really trauma events. You're still wanting to understand everything about that patient that you can. You're wanting to build that occupational profile in your head of what is important to this patient. Why are we seeing them? What are their goals? Very, very good. That was right on. So what or when should you modify an OT treatment, Cassidy?
Like if we're performing and like I don't feel like it's going well, or if it's something that they need to do and I don't think they can.
Just any scenario. When should you?
Like if
when should you learn to modify it?
If they're in pain or if they're just not at that level of functioning yet, maybe they don't understand the adaptive equipment presentation. Maybe scratch that idea.
Or if it's just not working.
Yeah. I don't know. I guess mostly if they're just in pain or they can't do it yet. If they can't, if they're having breathing problems due to like COPD with their injury, maybe modify it to be easier, do some comp strategies.
Got you. Sorry, it cut out. The internet's not crazy good here, but yes, exactly. I caught the tail end of that. If your OT treatment is not working, it's not successful with you, it's okay to modify it. It's okay to try trial and error things as long as you're being safe with the patient. Lindsay, when would you stop an OT treatment?
If they're having any like vital sign issues like blood pressure drops or raises really high, or their pulse ox would go really low.
Yeah, very good. Perfect, guys. All right, Isaiah, how can you manage the lines and tubes to maximize safety for you and the client?
Definitely have another person or also ask the nurse if you're unsure about if they can like bend certain parts of their arm or if the tubes will get in the way, stuff
what
like
that person is called is your spotter. Right. Absolutely. That person that's keeping a watch out for those lines, in that particular scenario was the nurse. You're worried about. Sorry, you're worried about the patient, right? And then the lines. If you have somebody else watching those, you can just focus on the patient and their balance and their safety, right? So it makes it a little bit easier if somebody else is the one watching those lines specifically to make sure that they're not being tugged on. All right, I'm going to go ahead and go through these last two slides. Hopefully it stays on for us. All right, so what kind of preparatory tests might you use? Therapeutic exercise. This might be range of motion, might be strengthening, might be a short aerobic thing to get them ready to go for this. An orthotic, that's a preparatory task to keep their hand in functional position or whatever it may be, to get them ready for whatever intervention you're about to do with them. Environmental modifications, this is all things that are preparing you in order to do some type of a task. A physical agent modality, maybe putting heat on their shoulder or whatever before range of motion, manual therapy, like massage or whatever. Then functional mobility of just getting them walking or walk up, wheelchair bound, whatever, and rolling. All of this stuff is preparatory tasks in order to get them to do a treatment. Okay. So what kinds of occupation-based interventions might you use? It really just depends on your person. Remember, keeping them occupation-based but specific to your patient is very important. Finding out what's important to them. Polytrauma it absolutely affects every area of your interventions, but that doesn't mean you can't find one. You kind of have to find one, right? Just because somebody has a TBI and a broken leg, okay? Just because they have you can't work with them on putting on a shirt or putting on pants. You might have to do it differently and figure out a new way to do things. That doesn't mean you just don't. You absolutely can. And then what kind of client and caregiver training and education might you incorporate? Constantly. What type of you may do visuals, you may do specific training. One of the more successful methods is having the caregiver watch you do it, get them prepared, give them education about it, and actually being right there with them and having them perform a transfer or helping them get dressed with the calm strategy or whatever. Have the caregiver there, have them try it. I've done that so many times, and it's way more successful because they feel comfortable. They're not just, winging it at home with a paper that you gave them. They are doing it with you right there beside them. If they have any questions, they can ask. That is much more successful than just trying to say, okay, here's your educational handout. All right, guys, are there any questions on this chapter? No? Okay. So you guys I'm pretty sure you can do a knowledge system this week. I haven't even had a chance to open that on eLearn yet. But anyway, by the end of this chapter, you should be able to answer the following questions: true or false. If a client has a possible DVT, is it okay to keep treating them if you do it bedside? 2, you cannot treat a client who is on a mechanical ventilation. And 3 is clients taking medication to regulate blood pressure may become dizzy and unstable during treatment. 3 pretty simple true false questions. And let me go.